Right, good afternoon, everyone. So before I start, could I just make sure that people online could actually hear what I'm saying? Could someone just confirm?
Yeah,
We hear you loud and clearly.
Great, thank
can
you very
hear.
much. So good
Yeah.
afternoon, good morning, good evening, if you're joining online from different parts of the world. So it's a real pleasure to be standing in front of you today to introduce and to announce the launch of Search, the Southeast Asia Registry. Search actually has a very nice name, Southeast Asia Regional Collaborative for Health. And I have to say that while I'm the spokesperson to open the ceremony, this is really the brainchild of very hardworking and forward-looking people like Swee, who is here, together with Jeremy. These are the leaders in global health, global public health, that is really looking at what are the needs and areas that we need to plug gaps, particularly in Southeast Asia, around global health developments. When we think about global health, one of the key areas is always around the attainment or the vision and aspirations towards universal healthcare, UHC. Very simple concept that was introduced by WHO with 6 particular targets, but from a strategic purchasing or from a strategic financing perspective, it's never that straightforward. Because when we think about healthcare financing, the SAFE, S-A-F-E principles always come in around sustainability, adequacy, fair, and efficiency. And when we think about strategic purchasing, it's really trying to make that one additional leap towards achieving sustainability as well as efficiency. And that is where certain governments, some governments in Southeast Asian countries already have established government units that are looking at how to price the value of drugs, medical technologies, innovations for population level launch and rollout. Now, with this engine that Search is going to put together around strategic purchasing, it is one additional platform and initiative that we hope is going to help countries in Southeast Asia achieve that aspiration of UHC, focusing perhaps on strategic purchasing at the right price, and as well as looking at what are the gaps in their primary healthcare rollout. Now, the School of Public Health at NUS is very privileged and delighted to be hosting this platform and this innovation. We work with the governments of Southeast Asia in many different regards. Governments from Thailand, from Indonesia, from Philippines. We have our 2 regional offices in Cambodia, in Laos. Those are initiatives that we believe is going to make a difference of why Search is going to be perhaps more likely to succeed compared to previous similar initiatives that have failed. Because of this partnership between an academic institution that is guided by principles around value, around prevention, around the aspiration of UHC, together with governments in regional Southeast Asian countries. So while we have achieved those aspirations to establish Search, I think it is important to highlight that this is not solely a Singapore-driven initiative. The success must come from the partnership between Singapore, between the NUS School of Public Health, with the collaboration of regional governments and their corresponding units that are looking at financing, drug procurement, and even primary healthcare development and rollout. So it has been a real privilege for us to think through how do we develop this, and definitely a call out with gratitude to the Bill and Melinda Gates Foundation for supporting and believing in us to fund this early step. But as I mentioned to some of you earlier on, that the success of this fundamentally requires the buy-in from governments and from multiple agencies within each country, because in many countries, the procurement of drugs, it's still in a different division in the Ministry of Health or Ministry of Public Health or Ministry of Health and Sports, depending on which country you're from. Procurement of drugs is in a different division compared to deciding on healthcare financing and on deciding on what is the right value for money, the cost effectiveness. And for this to succeed, we actually need all the different agencies to come together. This is just a beginning step, but it's a real pleasure that we are able to take this step together. So with that, thank you very much, and I look forward to the rest of the event today. Thank you.
Thank you, Prof. Teo. I'd now like to invite Ms. Capucine Barcelona to present the registry. Capucine is a researcher in global health at the Swee Hock School of Public Health, leading this strategic purchasing project alongside Associate Professor Jeremy Lim and Honorary Visiting Assistant Professor Swee Kaur. The registry is a descriptive overview of the health purchasing landscape in Southeast Asia. Capucine, over to you.
Distinguished guests, speakers, and audience members, thank you for attending the launch of the Southeast Asia Strategic Health Purchasing Registry here today, prepared by the Search Network, the Southeast Asia Regional Collaborative for Health. I will address 3 topics in my speech. Number 1, why is strategic purchasing important and why we chose this research subject? Number 2, what the genesis and aims of the registry are. And number 3, 3 broad findings from the registry so far. So part 1, why strategic purchasing is important. As Prof. Teo has shared, the Search Network was established to enhance capacity and knowledge on UHC in Southeast Asia. There's a pressing need in Southeast Asia to make the best use of scarce healthcare resources. Already prior to the COVID pandemic, many Southeast Asian countries had constrained resource bases for health. In the Philippines, Vietnam, Indonesia, and Cambodia, less than 200 USD was spent on health annually per capita. The number was less than 100 in Lao PDR and Myanmar. In comparison, the global average healthcare spend per capita is over 1,100 USD. Even as total health expenditure continues to rise, prioritizing where and how to spend will be essential to achieving UHC. Currently, public spending on health in most ASEAN countries is inefficient. It is fragmented among national and subnational governments, insurers, and out-of-pocket payments. Government procurement is not done strategically, efficiently, or transparently, including in the health sector. Although higher expenditure is generally related to better health outcomes, more money alone cannot achieve UHC. Some countries have achieved good coverage and health outcomes, even with limited resources, thanks to their efficient use of funds, as shown in the above graph. Achieving allocative efficiently will be essential for Southeast Asia. Strategic purchasing is an important tool to set priorities, free up fiscal space, and optimize the cost efficiency of care. The WHO has identified purchasing as one of the 3 core pillars of health financing. Purchasing refers to the allocation of resources to buy healthcare goods, including drugs, medicines, and vaccines, medical devices, and healthcare services, including consultations, surgeries, and facilities management. In strategic purchasing, there is a constant search for the most efficient and impactful purchasing decisions. This is driven by data on a country's health needs, on healthcare provider performance, and on evaluation of past purchasing decisions. Strategic purchasing has already been associated with improved care quality, access, and financial protection in sub-Saharan Africa. Various strategic purchasing pilots have also been conducted in Southeast Asia. Nonetheless, there's little consolidated information on the region's healthcare purchasing mechanisms and ongoing strategic purchasing initiatives. This ties to part 2, what we aim to do with the registry. Our registry gives a descriptive overview of the regional landscape of health purchasing. We hope for this to enable cross-country comparisons, mutual learning opportunities, and further evaluation of Southeast Asia's strategic purchasing performance. The registry was prepared by researchers from the Swee Hock School of Public Health and by research partners, or country conveners, from across the region. First, we conducted a comprehensive literature review of peer-reviewed articles, legal documents, and policy reports. We then conducted interviews with key informants from each country, including health financing policymakers, academic experts, and procurement practitioners. We thank all our informants for their generosity and insights. Finally, our data was synthesized into the registry. The registry enables easy viewing of purchasing initiatives across 3 main areas: governance, legal and policy, and performance monitoring. In the governance section, we overview the setup of each country's health financing and purchasing. In the legal and policy section, we overview the regulations that govern public spending and health procurement. In the performance monitoring section, we share what each country does to assess health system, purchaser, and provider performance. The registry is now available online at www.blog.nus.edu/searchsp and accessible via the QR code above. The site also contains FAQs and resources on strategic health purchasing. We invite you to explore the site and remain up to date with our work. Based on the descriptive overview from the registry, we are now working to evaluate each ASEAN country's performance in strategic purchasing, what is being done strategically and what is being done less well. We will prepare national and regional policy recommendations later this year, aiming to enhance preparedness for future strategic purchasing. Several individuals and groups are to thank for the development of the registry. We are grateful to the Bill and Melinda Gates Foundation, particularly Stefan Nachuk, Dr. Hong Wang, and Ethan Wong, for their funding, network, and technical support. From the Swee Hock School of Public Health, we thank Associate Professor Jeremy Lim and Honorary Visiting Assistant Professor Swee Keng Kaur for their leadership on the project. We also thank other members of the search network based at the school, particularly Associate Professor Helena Lejido Quigley. Finally, we thank all our country conveners for their research and network building efforts. Now, part 3, some preliminary findings from the registry. Through our research, we have already encountered some key themes on the state of strategic purchasing in the region. I will briefly share about 3. Not surprisingly, there are highly diverse health financing and purchasing mechanisms across the region. Some countries, like Thailand and Indonesia, have established purchaser-provider splits. The principal health purchaser is separate from healthcare providers and has autonomy over fund distribution and contracting. Other countries, like Brunei, integrate the purchaser-provider function in their respective ministries of health. This diversity may pose a challenge to regional collaboration, as one country's strategic purchasing initiatives may not necessarily apply to the other. Nonetheless, collaborative learning networks identifying best practices can mitigate these challenges. We hope for Search to become a platform for such learning. Number 2. Overall, strategic purchasing in Southeast Asia is in its early stages. ASEAN countries can be grouped according to different levels of maturity. Innovators like Singapore, Indonesia, and the Philippines are investing in their strategic purchasing capabilities, scaling up their national health insurance, centralizing health procurement, and transforming provider payment mechanisms. Learners, like Lao PDR and Cambodia, are implementing health financing reforms to lay a foundation for future strategic purchasing. For example, setting up provider payment certification mechanisms to ensure accountability. Finally, countries like Brunei and Myanmar have yet to implement purchasing reforms, but are looking to global experiments and considering how these might apply to their local contexts. Number 3. One common challenge, especially for low and middle income countries, is that of proper health and financing data systems to support strategic purchasing. Most ASEAN health systems are characterized by data fragmentation and non-interoperability. In some countries, health facilities lack access to IT systems and rely on paper-based reporting. Even when health data is available, this may not capture all the relevant information to enable strategic purchasing, such as financial, utilization, and individual patient data. The data collected is therefore not used to inform policy and purchasing decisions. Having provided an overview of the need for strategic purchasing and outlined the broad aims and findings of our registry, I will now hand over to 2 country conveners to share more about our research process and to present their respective country findings. Thank you very much.
Thank you, Capucine, for those insights. Now, 2 of Search's regional research partners, the strategic purchasing country conveners, will share about their research process and main country findings through pre-recorded videos. Dr. Tu Ha Nguyen is a lecturer in the Department of Health Policy and Economics at Hanoi University of Public Health from Vietnam. And Dr. Tipakorn is a lecturer in the Economics Department at Thammasat University from Thailand.
To track the state of strategic purchasing and UHC across ASEAN, we collect and analyze data of the indicators on governance, legal and policy landscape, and performance monitoring. We conducted the literature review and key informant interview. Specifically, our desk research covers the main sources of health financing, main strategic purchasing units, agencies or institutions involved in health purchasing, market structure, criteria to determine how and what purchases to make, and main stakeholders of decision-making on health financing and strategic purchasing. We also review laws and regulations that define the mandates and roles of purchasers and service providers, healthcare purchasing, public budgeting, and government procurement on healthcare. We also synthesized knowledge on performance monitoring, such as accountability frameworks, output-based incentives, processes to assess and feedback on the performance of suppliers, data and information management systems, and key indicators on health outcomes and the health system. For the key informant interviews, I interviewed top officials from the National Health Security Office, or the NHSO, which covers about 75% of the Thai population. The NHSO is a champion of universal health coverage in Thailand. And we have seen much progress in the NHSO to support the population's needs. I also interview leading scholars on health policy and systems who are pioneers in research on health financing and strategic health care purchasing of the UHC in Thailand. Finally, our research team synthesized findings and completed the strategic purchasing registry by ASEAN country. Our project team will disseminate our research through media pieces, peer review publications, and policy reports. In Thailand, the UHC system is completed by the National Health Security Office, or the NHSO, which is responsible for the purchase of health services from both public and private providers. The NHSO is a champion of UHC from the systematic and comprehensive mechanism of governance and performance monitoring. The well-established legal and policy landscape allow the NHSO to be accountable for people, healthcare providers, and the government. The NHSO uses a variety of purchasing strategies, including closed-ended provider payment, promoting gatekeeping functions at the primary healthcare level, exercising collective purchasing power, and engaging the views of stakeholders in the decision-making process. Strategic purchasing plays a very central role, along with the continuous effort and leadership of the NHSO.
Saya sudah
It
masuk.
could ensure the efficient use of limited resources
Oh, oke.
cost
Let's see.
healthcare services.
Ya. Dikirim kemana? Ke yang
Secondly,
90 ya?
The NHSO collects, utilizes, and monitors microdata on treatment and reimbursement, which could reflect the cost and efficiency of strategic purchasing. Therefore, the National Health Security Office, or the NHSO, and the Ministry of Public Health have used evidence-based research and theoretical concepts on monitoring and improving health system performance. Both NHSO and the Ministry of Public Health have utilized evidence and policy recommendations from the academic research units for the system-level analysis. Therefore, strategic purchasing in Thailand can have evidence to inform policy-making decisions by reporting to the Parliament or the Cabinet on the UHC's performance. Last but not least, there are inequality gaps in benefits, health coverage, and contribution relative to the other two UHC schemes. Therefore, we should extend the strategic purchasing mechanisms to the other two schemes as well. This will improve the budget efficiency of the overall strategic purchasing of healthcare services for the country.
Good afternoon, everyone. My name is Hà Nguyễn. I'm a lecturer and researcher from Department of Health Policy and Economics, Hanoi University of Public Health, located in Hanoi, Vietnam. I spent the last 15 years observing, studying, and lecturing about health financing system and related issues in Vietnam. It is my honor to be here today to talk about the Vietnam Registry. My talk will answer two main questions. Firstly, to describe the research process for the registry, and secondly, to explain some of the key findings for Vietnam from the registry. So at first, let me share with you some slides. Okay. As mentioned earlier by the NUS team about the research process, after having an agreement among conveners about the study protocol, my colleagues and I conducted the desk study and in-depth interviews to gather information to develop the registry for Vietnam. For the desk study, we did perform a scoping review on the strategic health purchasing topic in Vietnam, research PubMed, and employed the Google Scholar tool to search for relevant publications. We also manually searched the websites of the related stakeholders, such as the Vietnam Ministry of Health, Vietnam Social Security Agency, which is responsible for managing the social health insurance fund in Vietnam, the Vietnam Health Strategic and Planning Institute, and other international organizations such as the World Bank and the World Health Organization. We also extensively searched for the related regulations in the two large legal document database in Vietnam. Other documents provided by the key informants were also reviewed. For the qualitative interview, we intentionally invited 5 key informants to gather in-depth information on strategic purchasing in Vietnam and cross-check with the information we gathered from the scoping review. All the key informants are leaders or senior researchers with more than 5 years of experience in the related field. They come from different organizations as listed in the table above. The results from the desk study and in-depth interview have bring the most updated information into the Vietnam Registry. The registry offers an overview of the health financing status of our country, and it is divided into 3 main sections, including the government, the governance, the legal and policy, the performance monitoring landscapes. You can look at the registry website and find detailed information for Vietnam and other countries later on. Because of the time constraint, I only selected some key points to talk about. Before starting, I would like to briefly provide some background information about the health financing system in Vietnam. So in Vietnam, social health insurance and the state budget are considered the two primary sources for healthcare. The two public sources contribute to half of the total healthcare expenditure in Vietnam. The social health insurance, with a coverage of 91% in 2021, is the dominant public source for curative care. Meanwhile, the state budget mainly covers preventive care and the expenditure for non-autonomous hospitals. If you look at the Vietnam registry later on your own, you will see we try to give an overview of related stakeholders involved in the management of the two financing sources. Results from our work confirmed that there is no dedicated national unit or specific national policy for strategic health purchasing in Vietnam for both schemes. The two main characteristics of strategic purchasing, which is actively allocating budget to providers based on an assessment of population health needs and based on the assessment of the provider performance. They are not fully mentioned in any policy documents. However, the size of the strategic purchasing function is recognized in both schemes. Let me make some example of it. For example, there are some criteria such as the healthcare needs, effectiveness, the cost effectiveness criteria regulated by the MOH for selecting the medicine into the social health insurance benefit package. In terms of the state budget, the law on state budget regulates several criteria for allocating state budget, such as based on the assigned objectives, which generally cover the health needs of the population. Some prioritize public health programs, such as HIV/AIDS program, that actively employ M&E data, including need assessment and service providers' performance in making their strategic budget. However, the remaining purchasing functions are implemented in a more passive way. For example, state budget allocation is still heavily dependent on the previous year's expenditure, or has been no effort to select providers under both schemes. The provider payment mechanism remains an input-based approach, although there are several efforts to reform the provider payment methods to DRG and capitation recently in Vietnam. And finally, although having regular national health M&E activities, the data not yet been linked to the purchasing decisions. In summary, I would like to mention that the registry is the first step to understanding the strategic health purchasing prospect in Vietnam, as well as other Southeast Asia countries. Compared to other countries, Vietnam is in very initial stage of strategic health purchasing. I think it could be explained in the way that as a limited income country, we have been focused on the first function of health financing, which is raising enough money for healthcare. So in the upcoming period, there is a lot of work to make our purchasing more strategically. To do so, I believe that Vietnam also has its own advantages. For example, our health financing system is based on public source rather than other private source, including social health insurance and state budgets. And both schemes, both funds are managed in a centralized and uniform manner. These findings could facilitate further performance evaluation of Southeast Asia countries in strategic purchasing. It could provide local policy makers in Vietnam and also other countries valuable lessons learned from the neighborhood countries and context specific recommendation toward strategic purchasing. Thank you very much.
Thank you to our country conveners. I hope you found those presentations insightful. Next up is an exciting panel discussion about the challenges and opportunities for strategic health purchasing in Southeast Asia. We have an impressive line of panelists, including regional experts in health economics, financing, and procurement, with a few joining us in person as well as online. It gives me immense pleasure to introduce and invite on stage Mr. Chan Beng Seng from the Singapore Ministry of Health, Mr. Sebastian Chua from the Singapore Health Promotion Board, and online we'll have Charlie Villasenor from the Procurement Supply Institute of Asia, Dr. Haspala Tabrani from the Indonesia Health Financing Activity, Dr. Buafat from the Lao PDR National Health Insurance Bureau, and Dr. Muhammad Wahab from the Malaysia Ministry of Health. And today's session will be moderated by Ms. Capucine Barcelona, Global Health Researcher at the NUS School of Public Health. Capucine Barcelona, Global Health Researcher at the NUS School of Public Health.
I don't think this. Hello. Okay. Yes. Great. Thank you very much, Nikita, and thank you again for all our panelists, both in person and online, for being here. Maybe we can project the online panelists on the screen for the in-person participants to see. So hello, and thank you to our online panelists as well. So we'll begin with the panel discussion now. So having spoken a bit about the registry, some of our aims and findings, we're now going to shift gears a bit and we'll have a broader discussion about some challenges and opportunities for strategic purchasing in Southeast Asia. So we have with us today a very impressive panel of speakers who are experts in healthcare financing, health procurement, and strategic purchasing. Our panelists come from all around the region. We have some in-person panelists here from Singapore. We have panelists from Lao PDR, from Indonesia, from the Philippines, as well as from Malaysia. And all come from different backgrounds, all within the field related to health purchasing. So now I'd like to start with my first question, and I think we'll begin with the in-person panelists in Singapore and then move on to the virtual panelists. So I'd like to hear your reflections on the main challenges that your country is encountering with regards to strategic health purchasing, perhaps talking about the last 5 years or so. So maybe Mr. Beng Seng, would you like to start?
Thank you. Thanks also, Capucine, for the presentation. It helped me get a much better appreciation of what this registry is. I think it's a great initiative, very timely one to have this. Well, I think from the presentation, I realized that this project is even more ambitious than what I thought it was. I had thought it was about how you procure strategic, but actually it's more than that. It even captures how the different healthcare financing systems are in Southeast Asia. I would outline first that what I will share is going to There's the healthcare financing part, which I'll set aside for now. I shall focus on the part about how we in Singapore have been thinking about procuring strategically over the last 5 years. And when I say that, I mean about procuring things like supplies, services, as well as equipment. How do we buy these things strategically? Yeah. Now, in Singapore, if you look at our total healthcare costs, you'll be looking at about manpower representing about 60% of the cost. Most of the rest, much of the rest, is actually as I said, mentioned the supplies, the services, as well as the equipment. So, if you want to make healthcare affordable, you want to manage healthcare costs. Actually, you can't ignore this significant part of the healthcare costs. So over the last 5 years, I'll outline 3 different areas, aspects of which have sort of stood out for me. First, 5 years ago, Singapore public healthcare system were generally buying all these supplies separately, meaning not as a single entity. We have many different public healthcare institutions in Singapore, and many of them were each on their own procuring what they needed. Well, I think it's quite apparent to all of us here that there's a lost opportunity. There's scope to bring together the procurement activity, not just from the standpoint of efficiency, but from the standpoint of leveraging your bargaining power to achieve better prices. So that's what was done. So 4 years ago, the procurement functions across public healthcare in Singapore were consolidated into a single entity. The entity is called ALPS Private Limited. It's a company just like all the other public hospitals are companies. And that entity now is charged with the role of centrally purchasing all the supplies needed for public healthcare. In fact, I've just joined ALPS from Ministry of Health. And that entity is now in the position to slowly consolidate the contracts, the individual contracts which all the different hospitals have established into single contracts and getting better value out of that. So that's one of the changes that happened in the last 5 years. Another important area that we've been working on in the last 5 years is how you link your healthcare financing policy with your decisions in purchasing. What I mean is this: it's like if there are certain things that whether or not when you buy certain sort of take drugs, for example, probably is the easiest example. If the drug is paid for by the payer, the volume is the utilization will go up, right? So if there are subsidies for a particular drug, you can expect more of it to be used as opposed to another drug which the patient has to pay for himself. Therefore, actually, health financing policy, what drug are you going to fund, actually can influence the ability to drive prices down from the vendor. If you wind back years back, this decision was separated. What we decided to fund from a healthcare financing standpoint at the ministry and the prices that we secured were separate activities which never joined. So over the last 5 years, though that coordination has been brought about. So what this is that in order to get on let's say a subsidized list or a list of to be funded by the government, vendors had to offer better prices, because in doing so, we could justify let's say a drug to be subsidized because its value would have gone up. So that process has been put in place. An important agency that plays this role is actually the Agency for Care Effectiveness. Some of you may have heard of it. It is a very technically strong agency which performs health technology assessment. It evaluates the benefits that any medical technology brings, the price that we should be prepared to pay for it, And with its assessments, we are better able to evaluate what technologies should and should not be financed by the Ministry of Health. And that process has helped bring about significant price reductions. I've seen examples of 80% price reductions actually. So where that this approach can be applied, it can be very effective. But there's of course some limitations of when it can be applied. You need to be able to evaluate the technology in that way. And not all technologies are so easy to evaluate. So drugs is just one area where it's very well established, and the Agency for Care Effectiveness have been moving into other areas where it's possible to apply this approach. And if you look, now let me move on to my third point. Now, if you look back 5 years, I think it's hard to talk about the 5 years without mentioning COVID, right? So COVID was, I mean, besides all the various stresses it's placed on the healthcare system, one of them is a supply shortage. So I think the COVID episode, COVID has drawn out the importance of supply resiliency now. So it was fortunate for Singapore that the ALPS had been set up before COVID struck, because with ALPS established, there was a point agency which could go out there and secure supplies when there were breakages in supply, instead of having many smaller teams doing this job in the distributed way. We had a single national entity which could lead the effort. And therefore, it was fortuitous for Singapore that we had set this up at that point when COVID struck, and could tap on this organization to go out there to find the supplies which were now all scarce. And not just it was important not just to secure supplies, but also to ensure that the supplies were properly distributed in our national health system. Now, if we did not have a single entity, frankly, you wouldn't know where the needs and where the stocks were. And but because there was a single entity which had this overview, we could make sure that we minimize. We didn't have like excess somewhere and shortages elsewhere. You could better make sure there were equalization across the country. Yeah, so if we have time, I can talk about healthcare financing later, but for now, maybe I'll stop there on what the last 5 years has been for me in my mind. Thanks.
Thank you very much. So those are really interesting insights about both the need to look at the healthcare supplies and healthcare goods side, as well as the healthcare financing side and healthcare services side. So before we move on, and I want to hear from Mr. Chua, because I know the HPB has been very involved in the COVID response in Singapore. Maybe I'll slightly change the question, because you've given us a very insightful overview of everything that ALPS and the Ministry of Health has done overall. Perhaps if Mr. Chua, as well as all of our next panelists, could talk about some challenges that have been encountered in the last 5 years, as well as maybe giving an overview of what has been done and opportunities as well that you see for enhancing strategic purchasing. So let's combine the challenges question and the opportunities question together. Perhaps they're quite related.
So thank you for inviting me to stage. So I'm looking for Health Promotion Board as the head of the department. So I'm a procurement person working in this sector for the last 30 years. And in the last 10 years with the government agency. So let me share what do I see as a procurement person, the challenge faced by us. There are internal and external challenges. So I'll cover the internal challenge. Internally, I believe the single biggest challenge for procurement people like me has always got to do with stakeholder leadership. Procurement is not just about buying, it's about building value. And thereby procurement has to constantly sell our value. And the challenge is not in extracting the value. The challenge is more in communicating the value to our business leaders. ultimately value is in the eyes of the stakeholder. And therefore, to transform the stakeholder leadership, procurement has to demonstrate that we can.
Sorry,
Now,
apologies, Mr. Chua. I think some Zoom participants aren't able to hear clearly, so perhaps maybe you can try my mic or hold it closer.
okay, so I repeat, thank you. So to transform stakeholder leadership, procurement has to demonstrate that we care, not just what, but how we care. And we know how we spell care, C-A-R-E, right? And what does C stand for? C is customer experience. The customer experience can be improved by changing the way we interact with people. But the change only happens when procurement can make an impact on the people's need. And that is a challenge. And what is A? Accountability. And to be accountable, procurement need to understand what are the drivers and the motivations of the people around us. And what is R? Relationship. And these need to be built outside of work. As a procurement person, we need to show that we are now doing things differently rather than doing different things. And to remain relevant, we should not be managing the processes to meet the functional objective. That is easy. What is more difficult is, it is more critical for us to manage the relationship to achieve the business strategy. And lastly, what is E? Empathy. And this is so important but hardly mentioned. Relating with others is just as important as working with others. And this explains that sometimes it is more important that we remain kind than to be right. And many times, what most people want from procurement is not a clever mind that speak, but a special heart that listen. So this is what I see as the challenge in driving procurement, whether in public sector or private sector. And we know to transform, we must be prepared to accept that there will be some risk of failure. And most people, including myself, we are fearful of failure. So fear has two meanings, right? I repeat, fear has two meanings. Either we forget everything and we run. That is fear, right? F-E-A-R. Or we face everything and we rise. The choice is ours. And the conditioning of the mind is very powerful. If we condition ourselves to be tied down, we will lose forever. And thereby, believing that we can become successful is the most important step in achieving it. Right? So I cover the internal challenges that I see as a procurement person. So let me talk briefly about the external challenge. Yes, externally, we face two pressures. Number one, inflationary pressure. Number two, supply chain disruption. And how do we go about strengthening our supplier risk management? So internally in HPB, we have established a supplier risk management framework to provide us with a systematic three-tier approach to manage our key outsourcing risk. Tier 1, risk identification. Tier 2, risk analysis. Tier 3, risk control and reporting. And for every outsourcing contract, we complete a risk register that include, number one, what are the key risk drivers, i.e., what are the critical failure points? Number two, what are the mitigation control or measure? Number three, what are the additional risk treatment plans that we need to achieve a low target risk? Number four, what are the key risk indicators to monitor the risk? And lastly, quarterly supplier business review for us to validate the effectiveness of our risk treatment plan and to understand whether there are any emerging risks. Right, so I'll stop for a while before I talk about the opportunity. Maybe I have my colleagues on the line to share about their challenges too.
Thank you so much for sharing. So thank you for both of our in-person panelists. Now we'll, sorry, I'm not sure if you can hear. We'll move on to the online panelists. So maybe I'll invite Dr. Hasbullah Tabrani to share about some challenges and also some opportunities that you see for strategic purchasing. So feel free to speak about the health financing perspective as well. So just to let everyone know, we'll have about 20 more minutes of the panel and then move on to a Q&A section. So if you have any questions for the speakers, just hold on to them and we'll get the chance to ask later on. So Dr. Tabrani, would you like to go ahead?
Yeah, thank you, Cochin. Thank you all. First of all, I would like to just briefly discuss that the term strategic purchasing is just recently introduced by WHO. Its aim is making sure that we purchase healthcare, not only drugs, but that's healthcare overall, with most cost-effective way, cost efficiencies. Long before that, in the US, they call it integrated delivery and financing. It is the managed care technique where payment or purchasing the healthcare by insurance in the US, the HMO, packaging with a different way of package and price. Then the US introduced DRG, Diagnosis Related Group. In a way, it is also strategically purchasing because with this DRG or capitation payment, we transfer some risk. Otherwise, because of the stamp for strategic purchasing is the high information asymmetric in the healthcare providers. If you let the providers, the seller, package their products and price their product and sell it, certainly it will be very, very waste, not efficient because of the information asymmetric very high. And therefore, economic science try to find a way, the so-called strategic purchasing. In Indonesia, we already started using capitation payment for primary healthcare, where we put risk of inefficiency to the healthcare providers. And the DRG or CBG, we call it case mix group, for the hospital care. It is a package price, including the consultancy, the doctor fee, the medical devices, the supplies, the drugs, all into one package. We pay certain amount of money and we require them to produce outcome, which is the patient, if the patient seeks certain diagnosis, recover from that one. So that's a strategic. But the term strategic just recently introduced basically the same pattern. We purchase with special packaging, with special price that will link with the quality, with the outcome of the healthcare services. We can split into various services, drug and hospital price, or we can package into one package. Indonesia, since 10 years ago, we package into one. The primary healthcare, including medicine, doctor fees, all other consumable, using capitation payment under the national insurance or JKN. And for the hospital, outpatient and inpatient, we pay bulk payment. We have 1,075 different group of purchasing. That include drugs, include lab tests, include the doctor fee, and so on. With that, we purchase strategically. But we found out that's still not enough. About 4 years ago, under the health financing activity supported by USAID, we move forward for certain diagnosis, which is the maternity care and the tuberculosis. Both have some long-term impact because for maternity, you cannot pay per antenatal care, per visit, and so on. It will not be very efficient. And therefore, we try to package one payment from the beginning of pregnancy, the antenatal care, until the delivery and postnatal care, how much that price. Then we purchase the Dutch services with 1 or 2, 3 payment, but everything we calculate and pay linking with the outcome, with the improvement of the outcome of the delivery of the babies. And also we are now developing for the tuberculosis. Tuberculosis also requires 6 months at least carrying and eating drug. If we pay per services, it will not be efficient, will not link to the outcome. So this is what we are now implementing under the USAID project, but also before that in the national insurance already implemented. The result with currently we spend only less than 5% of what Singapore spend for the healthcare. Maybe the quality that's still debatable, but access currently 250 million people already registered in our national health insurance scheme. I think I stop there to give others a chance to speak. Thank you.
Thank you so much, Dr. Tabrani, for the overview of what Indonesia has been doing in recent years. So maybe now we'll move on to Dr. Fonvise from Lao PDR. Maybe just keeping track of time, if I could ask the panelists to keep their answers within maybe 3 to 4 minutes each, if possible, so we have time for audience questions at the end as well. So Dr. Fonvise, if you'd like to go next. Okay, if not, we can go to Mr. Charlie instead first.
Yes, I'm ready. Should I put my system on video?
Sure.
Okay. I think somebody has to make it happen or make the necessary controls and adjustments. But for the interest of time, let me proceed immediately while the controller is putting me on video. PASIA works around the globe on procurement. So we get to see many industries, and there has been a growing trend on healthcare engaging us. And these are the 5 things that we normally see. Number 1 is shareholder and stakeholder mandate. We have seen a growing and intense focus of stakeholders trying to make things better in healthcare procurement. What is the best practices that they actually put in place? Many of these organizations, both public and private, conducts what we call a current state assessment or a procurement health check to be able to justify both qualitative and quantitative of what needs to do. Second thing that is concerning the region is about corruption in purchasing. The biggest area among nations is having corruption at the healthcare industry. What do I mean with this? This is about ethics. In some regions, we see a lot of regions accepting money under the table. Some people are accepting money on top of the table. But in the ASEAN region, can you imagine? They even take the table with them when they do corruption. You probably have seen this on the news. Third item, talent development is the least that they are actually doing. I'm quite surprised why still people are talking about price. That is not strategic purchasing. When we look at price, we confine ourselves to very limited area of strategic sourcing or category management. What is most important is getting the most advantageous deal, with your business partners. Important is assurance of supply, quality service, cost, innovation, and regulatory compliance. We need to train people in depth on what strategic purchasing really is. There's so much things to say about that, but for the interest of time, I'll move on. The fourth item is really trying to adopt technology. It's so fascinating and unimaginable that many of the categories of spend in healthcare are subject to possible electronic auctions or e-procurement. But many organizations still doesn't put that in a ready play. So we need to ensure that technology is adopted by both public and private healthcare system. One of the companies, group of companies of 15 companies, hospitals that we have worked with, they were actually on the red. But when we actually focus on helping them make their procurement strategic, they actually turn into profitability in a very short amount of time. And the fifth item, this is not about purchasing alone. This is about end-to-end supply chain management. We normally call it plan, source, and move. It's very important that when you become strategic, employees and stakeholders gets to understand what we call demand planning, demand forecasting, demand management, inventory management, because this is where the money really goes to. It affects the income statement, the cash flow, and the balance sheet. So all I can say is like there's a significant work to do, and there's a lot of best practices that we have deployed this training on a virtual mode and on a face-to-face basis. But what we see among the healthcare industry is that there seems to be a lot of work, but there are a lot of best practices that we could copy shamelessly. I say shamelessly because best practice is already available, platforms are already there, but we need to really get the stakeholders and the shareholders adapt it seriously to make an impact to their countries and to their organizations. Thank you very much.
Thank you very much, Charlie, for those insights about collaboration and adopting best practices in regional context and national institutional context. So yes, the video should now be enabled. Apologies for the delay with that. So if you'd like to keep it on. Okay, maybe we'll move on to Dr. Anis first from Malaysia. So if you would like to talk a bit about some and opportunities you see in the area of strategic purchasing.
Right. Thank you, Kapusin. You can hear me clearly, can you? Yes. All right. Okay. So first of all, thank you to the Swee Hock School of Public Health for this honor to be here, albeit virtually. Goodness, listening to everyone, I must admit Malaysia is by no means as advanced as countries like Philippines, Indonesia, Vietnam, Thailand, especially with regards to strategic purchasing. So the challenges that we are currently facing may be challenges that all these other countries have already overcome long ago. But in general, we all know that there is uncertainty in purchasing health services. This is in regards to the uncertainty of health needs, which vary across individuals, geography, and through time. The uncertainty of even the utilization of healthcare, which is determined by choices of individuals. They can choose to whether to seek care or not, and whether they go to public, private, or even in our case in Malaysia, even to traditional, unconventional medicine as a means of getting healthcare. And of course, even healthcare itself can be provided and is greatly influenced by providers who may have a financial interest. So over the past few years, especially in the past 5 years, well, even before that, Malaysia has typically been very much a passive purchaser of healthcare. And by that, I mean, with regards to when we allocate budgets to public providers, it's mainly historical or simply based on inputs and norms. In the private sector, the payers are very much price takers with multiple payers. This can be seen in our private commercial health insurers, where they admit that they don't have the power or strength enough to negotiate prices with the private sector providers, and there's hardly any selectivity of providers. It's mostly a case of whatever providers are available, that's probably what they end up negotiating with, and there's absence of quality monitoring, and I'll talk about that later on. So when we're talking about the challenges that we face in Malaysia, I see it as having at least 5 challenges. Now, first is the challenge of having an implicit benefit package. Second is that the challenge of having provider capacity to deliver healthcare services. Third is the challenge of input-based financing that we are currently practicing in Malaysia. Fourth is the challenge to ensure equity to vulnerable groups. And the fifth is perhaps, we all have this problem, the challenge of aligning our objectives with that of our Ministry of Finance, for example. So the challenge of having an implicit benefit package, and by that I mean that there's lack of cost effectiveness and technology assessments when we determine priorities within that benefit package. Being implicit, we already know that the inclusions and exclusions within it are loosely defined. And even though we say that it's comprehensive, that comprehensiveness is not matched by sufficient resources. So that's that first challenge of having an implicit benefit package. The second, the challenge of provider capacity. Reality is that there's a mismatch of resources between healthcare providers in Malaysia, between public and private sectors. We know that even though in terms of sheer numbers, there are more healthcare facilities, be it at the primary care level or secondary tertiary level, when compared to public sector providers. However, with regards to the workload, it is very much skewed more towards the public sector providers. There's an absence of payer-provider split in the public sector, so that's also causing challenge. And there's no obligation to achieve standards through accreditation. So that's the challenge of the providers itself. The third challenge of the input-based financing. And as we all know, when having line item budgeting and salaries especially within the public sector, that causes limited flexibility to meet the needs of the population served. And as it stands in the private sector, it's mostly provider payments are done through fee for service. And while that can have advantages in certain needs of healthcare provision, it still very much leads to more financial incentive. And in this case, for providers to be even more incentivized if the population remains sick. So that's certainly a challenge. The fourth challenge of to ensure equity for vulnerable groups. So in the early 70s, Malaysia was quite successful in ensuring that the rural population had good access to healthcare. But now the demographics have changed, so we need to also take into account whereas those days it was the poor in the rural areas, now we have to consider the urban poor. And of course, with regard to the providers, it is very much concentrated in our urban population. And the fifth was the challenge of aligning our objectives to Ministry of Finance objectives. And the three main objectives that I see the Ministry of Finance having is cost control, administrative simplicity, and accountability and transparency. So while the first one, cost control, I think it was mentioned earlier, Sebastian, about the value. When you're purchasing for value, it's not necessarily the most cheapest of all things to purchase. So that we can have those arguments, so to speak, with MOF. Administrative simplicity, when we want to introduce provide all these sophisticated provider payment that might not be as simple as what the MOF would want to expect, but certainly that's something that is challenged. But certainly on the third objective, accountability and transparency, that would be something that we would be very much aligned, but not to the extent that there's trade-offs in terms of efficiencies because we're adding more bureaucracy and so on. So with that, I'll stop here first, and then we can talk later on when the forum goes on. Thank you.
Thank you very much, Dr. Anis. So especially for mentioning the health equity aspect, as well as I would like to emphasize your point on purchasing doesn't necessarily mean purchasing the least expensive item, good, or service, but purchasing volume. So that's really what we're hoping to look into with the registry as well. So now let's move on to Dr. Boafat, if you'd like to give your answer, and then we'll go to the audience Q&A. Again, any challenges or opportunities for strategic purchasing based on the Lao experience? I'm not sure if there's technical issues. Otherwise, I'll just try for a few more seconds. Okay, if not, we can I'll ask one of the questions first that was received on Poll Everywhere. So not everyone has to answer. I'll give anyone who wants to speak on this the chance. So the question is, thanks for sharing about ALPS, the procurement agency, and its success in Singapore. How do you feel about a regional procurement office? What are the challenges and opportunities in such an initiative? So maybe any of our in-person panelists would like to take this? A regional
office. Is it procurement of healthcare or just drugs or medical supply? What is it, the procurement? For the healthcare, certainly for a regional, maybe difficult. drug, but strategic purchasing does not focus on some drugs or medicines or supplies. Strategic purchasing deal with the overall aims of linking payment and packaging of the services with the outcome. The procurement only, this just, it's regular purchasing. We get only efficiency problems because of the volume or large scale. Yeah. But strategic purchasing will not be good enough across countries because differences in the delivery system, in the price and so on of the healthcare services and consultation or medical procedures. So what is the procurement? The procurement only apply for the material like drug or medical supplies. It is part of it.
Okay, thank you for that insight. So maybe we'll have someone from the procurement perspective to answer that. So either Mr. Chua, Mr. Beng Seng, or Charlie.
Yeah, maybe I could share a few things. Group buying or centralized procurement has many meanings. There are several things that you could organize, and we have done this with many industries with a lot of success already. So it doesn't mean that healthcare industry cannot do it. There's a significant opportunity to centralize, but there is also several approaches beyond just centralizing it. The key point there is to actually drive the entire concept of centralized procurement by applying two things. One is strategic sourcing, which is actually getting the most advantageous deal and working it on a category by category basis. Of course, you can centralize, but even the execution can be done by different countries or specific business units. So that is actually doable, and the leverage there is going to be very high for those who are actually involved into it. But that doesn't stop there. When I run big organizations and trying to centralize all of the procurement, there is such thing that we call Maybrick buying, because many of these units will still work with their favorite suppliers for various reasons, both appropriate and inappropriate. So one of the things that you can potentially do is to institute and institutionalize and use technology like electronic catalogs, electronic sourcing types of applications and category management. But all of these things has to be done on a step-by-step basis. People has done it already successfully in the past, because there is what we call the evolution, of industry group portals or verticals. But it's a high aim, but can be done with many great opportunities and benefits that can be derived out of it. Thank you.
Thank you very much, Charlie. Sorry, I think Beng Seng maybe was about to say something first, and then we'll go to Mr. Chua.
Hi, thanks. Well, not like I have any brilliant answer to this question, but I'll say that as the other panelists have said, there are probably a lot of issues to work through on regional procurement. But it's a very interesting idea, idea with potential. And the question is, in which area of procurement can this work? I think if we try and apply it to all procurement, I think we are probably going to find that, wow, we are probably going to be more reasons why we can imagine why it cannot be done than it can be done. But if we ask the question a little differently, perhaps, is there one or two areas where there might be there's a case for doing things together? The answer might be yes. The question is identifying those areas. We too have to bear in mind that I think it could be that some of the suppliers may not like this idea. Some of the suppliers may be separate, meaning they're separate suppliers in different countries, which adds to the complication. But I think that those are all part of working through what is possible and what is not in trying to draw some positive benefit from such an idea. Thanks.
Okay, so maybe I will share very briefly, right? We all see the value of centralized procurement, right? So I used to run an international procurement office. We buy for every countries that we operate. But I need to emphasize that we need to understand what is the definition of demand aggregation. We know what's the meaning of demand aggregation. You aggregate all the demand. Hopefully you get better value for money. But there are two principles that people do not comply when it comes to demand aggregation. Number one, are you able to commit the volume? Number two, are you able to commit the duration? This is the challenge that I faced in my procurement world in the commercial sector, whereby we buy for 100 countries, but every country will not want to commit the volume, do not want to commit the duration. So to the supplier, that is not demand aggregation.
Thank you very much for that answer. So now we've spoken a bit about the procurement side. So I want to go to one more question. Sorry, before we move on to the other poll everywhere question, it seems that maybe Dr. Boafat is able to join us now and share about Lao PDR's challenges and opportunities in strategic purchasing. So if that's the case, maybe you can unmute yourself. Okay, maybe not. So I'll ask the other question first, which is having spoken about the procurement side, I want to move on a bit to the financing side. So this goes back to all the points that have been made about linking purchasing to value and to outcomes. So the question is, how do you overcome differences between end user demands and costs, such as the use of biologics in cancer? So maybe we can just make it a bit broader in terms of financing for high cost or very expensive drugs or treatments. Maybe any experiences, any experiments from across the region that any of the panelists would like to share about?
Yeah, I could share that one. Yeah. As Mr. Anis mentioned, that there are uncertainty of the healthcare needs, uncertainty in terms of time, uncertainty of the volume, uncertainty of places, and therefore the best practice in the world, healthcare is financing become public financing. We cannot rely on individual financing. Certainly, it's very, very difficult. Should be public financing. Public financing can be government, like Malaysian model, or combined government and non-government, and delivery of care for cancer, whatever expensive medicine, can be in the public and private healthcare providers. This is the case in Indonesia when we pull all together into national scheme. Everybody contributes according to their income level. Which is currently 5% of their salary, then the right for the healthcare is related to the needs, not the contribution. This does not apply in the private sector. Private health insurance will not be able to do it, will not be able to meet the equity level. Only public financing that ensure equitable healthcare. The poor, even though they contribute only 5% of their say per 1,000 monthly income, that's only $50. If the healthcare needs for the cancer becoming 10,000 or 20,000, they still have the right to that because of the nature of the risk transfer of national insurance. So that's the way that all countries should go. Only two options: public provision like National Health Service, like Malaysian system, or the Indonesian, Vietnam, Philippines also doing that. That's the system. We cannot rely on private sector on this financing for equitable healthcare. Over.
Thank you very much. Maybe before we wrap up with this question, I would also ask Dr. Anis if there's anything that you'd like to add from the Malaysian side.
I think I totally agree with Pak Zubullah. Certainly, it has to be a predominantly public financing. That's the only way we can ensure that equity and that the healthcare is provided according to needs. Yes, and it can be either through general taxation or a contributory system. And for that extent, Malaysia is looking at both concepts and seeing what can make sense, both technical feasibility, financial feasibility, as well as political feasibility, and seeing whether we can go beyond our current system over.
Thank you very much. So it seems that we've ran out of time for the Q&A. So maybe I'll just check if anyone here live has any pressing questions that you'd like to ask. We can quickly take it. So if not, maybe I know there's still a lot more to say, and this is really just the start of the whole conversation that we want to have about strategic purchasing. So both including goods, supplies, medicines, health services, and financing. This is really just a small introduction to our project, and we're hoping to hold many more events this year and even in the coming years on the topic. Also considering that strategic purchasing is really a tool to advance UHC and not an end in itself. So actually, maybe before wrapping up, I do want to address one question that was asked on poll every year, which is, what are the benefits to there being a common registry rather than each country doing it themselves? So very briefly, we aimed to have a regional registry because there's a limited knowledge and cross-country collaboration on strategic purchasing. So countries are currently experimenting and setting up their own systems. For example, what Singapore is doing with ALPS, or how Malaysia is looking at what they want to do. But there isn't really a platform for knowledge exchanges on the topic, and we hope that through search we can build that platform. And we strongly believe that collaboration and mutual learning opportunities will help all countries succeed and improve faster in this regard. So I hope that answers that question. And maybe we'll wrap up the panel discussion here, and we hope to be able to carry the conversation further later in the year. And I'll hand it back to Nikita.
Thank you to all our esteemed panelists for this very insightful discussion. Ladies and gentlemen, we have come to the end of today's event on strategic health purchasing in Southeast Asia. I hope you found it fruitful and insightful, and thank you very much for joining us. Wishing you all good health and a very good evening.